Hello, my name is Dr. Benson. I am the Pulmonary Rehab Medical Director, and today I'm going to be going through medications used to treat lung disease with you. So this is kind of just an overview of how most pulmonary medications work. The thought is that we want to target making those small airways relax and able to open up and allow more air to get in and out, so relieving the constriction of those bronchial tubes. And by doing that, we actually relieve air that gets trapped within the lungs when those tubes tighten. Part of the way that we do that is to decrease inflammation that can be in those airways, although inflammation can be in multiple parts of the lung. We also want to decrease mucus production because sometimes it's not just the airways that get constricted. It can be that what we call obstruction, so that you're making so much mucus that it blocks air passing through those tubes. And then we also want to focus on treating or preventing respiratory exacerbations, whether that be from an infectious trigger, or sometimes the airways just get upset and start to cause the lungs to create too much mucus or too much inflammation within the alveoli. And so we want to reduce that burden. And again, also fighting infections that can result as a consequence of that. So sometimes people get a pneumonia as a result of an exacerbation from their lung function. So just reviewing how medications are taken, it's similar to how you take other medications that maybe aren't for your lungs. So medications that are used on a daily basis are called maintenance medications. And you think of these just like you would take a medication for diabetes or high blood pressure. You really want to maintain these inhalers or these oral medications regardless of how you feel, because they're keeping your lungs healthy. And then there's the as needed or the rescue medications. And these are for when maybe your lungs are flaring up, or sometimes people use the as needed medications before exercise. So in medical terms, we call that PRN, which is a Latin abbreviation. But think of this more as the ibuprofen you would take for a headache or Tylenol you would take for joint pains. You really only need to take it if you're feeling poorly. And then medications come in inhaled forms. So in nebulizers that are dispensed by a machine, we call metered dose inhalers or dry powdered inhalers. And those are just inhalers that kind of deliver medications in different mechanisms. Many of our lung diseases can be treated with oral medications. So these could come in pills or capsules or even syrups. And then sometimes some of our patients need intravenous medications, either again to maintain their lungs or for acute exacerbations. So if there's one thing that you can take from this lecture, it's that keeping an accurate medication list for yourself is the most important thing you can do. So not all of our medical records talk. You may see a variety of different doctors and things can change pretty routinely. So keeping a list that's updated and accurate, and then it's really good for you to know what the medications are, how they look, what they're called, why you take them. And it's not just about knowing the name of the medication. We always want to know the dose, how many pills, tabs, forms of liquid you take, and how many times a day. It's also helpful to have any over-the-counter or supplemental medications on that list because things can definitely interact even if they can be sold over the counter. Just keeping in mind that if you take vitamins or other types of as needed medications, it's important to have that on the list as well. So these are all the drug classifications that cover most of what we use in pulmonary medicine. And we're going to kind of go through how each of them work and what they do. But this is a pretty broad description of things that we use for patients with lung disease. So this is a nice chart from the Allergy and Asthma Network, basically going through why it's so important to know exactly what you're on. Because as you can see, there are a lot of inhalers out there. There continue to just be more, and they come in a lot of different varieties. So you'll see what most people are familiar with here are the kind of the puffer medications or the meter dose inhalers. And then there are other types of inhalers. So the Ellipta brand, the Discus brand, those are your dry powder inhalers. And then as you can see in the bottom, there are a lot of injection medications that we can use for certain types of lung disease, and then some oral medications down here that we're going to go into. One in particular is called Dalaresp. So inhaled medications, the three main types of medications we use are called work on three different types of receptors in the airways. So the first one is the most common one. It's called a beta agonist. This is how albuterol works, but a variety of other medications work this way as well. So albuterol is a short-acting medication, and then we have a variety of long-acting medications. And the idea with the beta agonist medications is that it relaxes the smooth muscles within the airway. So it actually works on the muscles itself. And then there's another class of medication called anticholinergics. These also work on the muscles around the airway. And they actually work on the nerves that are supplying that airway. So they work in a different area. These medications are really helpful for patients who have things like COPD. And then the last one we have are inhaled steroids, and it's just what you would think. There's a very small amount of steroid that you actually inhale, and the idea being that you're not having to take oral steroids because of the problems that can come with that if you take those chronically. And then you're really just targeting directly where that medication lands, and the idea is to decrease inflammation within that site. And then obviously, like I mentioned, you're probably more familiar with oral steroids or even sometimes IV steroids. So just to be specific, these are glucocorticosteroids. So these are things like prednisone, methylprednisolone. The idea is that you're giving a steroid that your body naturally makes, rather than, things like anabolic steroids. This is specifically a type of steroid that works just on inflammation. And we try to, again, reserve this really only for if you're having an exacerbation and those inhalers aren't going to cut it. However, some patients do have severe enough disease that they can't be off of an oral steroid. So we're typically trying to get them on another maintenance medication or a steroid sparing agent, because there are so many side effects to being on long-term steroids. You can't, once you've been on this for a long time, you can't just abruptly stop them. You have to allow those glands that naturally make these medication or make these steroids in your body have a chance to rev back up and start making your own intrinsic steroid for you before they're specifically just abruptly taken away from your body. We worry about people developing diabetes, glaucoma, having poor wound healing, having a lot of easy bruising. And then obviously there are things like weight gain, thinning of the skin that can happen when these are used long-term. So if patients have to be on it long-term, we try and get them on the slowest possible dose. These are two medications that are actually much older, and Theophylline might be the one that you're most familiar with. This is an oral medication that's been around for quite a long time. Some patients will say that they knew people who were on it in the 60s and 70s, and basically it works closely with the receptors that affect that caffeine acts on. And so it actually can bronchodilate or reduce that constriction within those small airways, not acting on the same receptors as the ones that you are using for your inhalers. Now, we do have to kind of use this cautiously because there can be some side effects, and you imagine they're just what you would think if you had too much caffeine or too many cups of coffee. You can get some nausea, shakiness, insomnia. If you get to really toxic levels, we can have patients who might develop seizures. So we usually have to watch this as we initiate this as a therapy. But if patients are really maximized on inhalers and still having symptoms, we tend to reach for this drug. And then I had mentioned on that chart in the bottom right, there's one class of medication called a phosphodiesterase inhibitor. This is a somewhat newer class of drugs that work by reducing inflammation. And it's the same idea. There's even another receptor on the smooth muscle of those airways that can be overstimulated when you have problems with your lungs. And specifically, we use this medication for COPD, although we're looking into other uses for other types of airway disease as well. So basically, you take this medication orally, it gets absorbed, and it travels to the airways, and it releases that smooth muscle. You get a lot of similar side effects as you do with the theophylline. So there can be some GI upset, notably some diarrhea, nausea, and then sometimes patients will have weight loss on this medication. So we make sure to only use it in a population where that would not be a safety concern. And then some other oral medications that are available, one that we call anti-leukotrienes. These work well, mostly in asthma. Sometimes if there's a COPD and asthmatic overlap component. They work specifically on a pathway within asthma that can be an overdrive. Usually it's patients who have environmental or exercise-induced asthma. We don't always know if that's the pathway that's affecting people with asthma, so typically we'll try this medication if somebody is not improving on his inhaled steroid and see if they reap any benefit. The most common one out there that we use is called Montelukast, or what the brand name is called Singulair. And again, side effects of that medication tend to be nausea, headache. Sometimes there can be problems with liver function. Most commonly, though, I think people complain of fatigue, so sometimes we instruct patients to take it at night. Now, mucolytics are kind of what it sounds like, medications to help break up mucus. And basically what that does is there are certain types of diseases where mucus can become very hard and dried out, and that can make it really difficult to what we call mobilize or get it coughed up or expectorated. So there's not a lot of evidence that these are necessarily beneficial, and we do have to use them in the right population. So some of the older, or one of the older medications is called acetylcysteine, or the brand name is called Mucomyst. This medication has kind of fallen out of favor because it hasn't been found to be very effective, and it has a pretty terrible smell. The other medication we use very commonly in the cystic fibrosis population is called Dornase, or the brand name is Pulmozyme. And basically you nebulize that medication, and the idea is that it breaks up kind of the cellular material within mucus. As I mentioned, we have to use this pretty judiciously because there are some side effects, and we want patients to really know exactly what those side effects are and how to manage them. But Again, the Dornase or the Pulmozyme is a mainstay treatment for some CF patients. And then we use things to help patients get rid of those coughs. And so we're really wanting to know exactly what's triggering cough, and that will help us target how to treat it. So not all cough is the same. If you have a cough because of mucus production, then we're going to focus on thinning that mucus so that you can get it out and hopefully reduce the amount of cough that you have if you can be more effective at clearing the mucus. Now, ideally, we want to decrease why that mucus is happening as well, but in some patients, that may not be possible. So we use a thinning medication. The most common one is called guaifenesin, also known as Mucinex. Again, side effects can be nausea, vomiting, dizziness, headache, and then rarely a rash. This actually works really well in conjunction with that airway clearance that you all will either be hearing about or have heard about. But it works even better if you can also stay hydrated. So if you are a patient who doesn't have fluid restrictions or concerns about your fluid status, we really encourage to make sure that you are drinking plenty of water, because all of that hydration actually helps that guaifenesin work better and allow you to be able to cough out that mucus. Now, what most patients really want are cough suppressants. So this is when, this is to actually stop you from coughing. But just remembering that cough is a reflex, and it's usually in response to something. So if it's those airways closing, if it's too much mucus within the airways, we don't want to suppress the cough if we're suppressing another problem. So some patients do have a chronic cough that isn't from those issues. And so we work on trying to help them suppress their cough in other ways. So you might have received like Tylenol with codeine if you had an illness. So codeine or opiates can reduce cough. And then there are some other medications used for what we call neurogenic cough. So some medications we use for neuropathy called gabapentin or Neurontin we can use for chronic cough when patients have really failed everything else. And then antibiotics. So typically antibiotics are used to just treat bacterial infections. And we know that in some pulmonary diseases, an overgrowth of kind of the normal flora that certain patients have can cause an exacerbation. So sometimes we will use antibiotics in that situation. We try and go based on some objective data. So if you truly have a pneumonia, we try and identify if we know what bacteria is in there so that we can target a specific organism. Sometimes, or most of the time, we don't actually have that information, and we end up needing to cover more broadly, and we kind of look at you as a patient. So are you living in the community, or are you living in an assisted living facility? Are you living in a nursing home? Do you see a lot of antibiotics, and are you at risk for developing resistance? And then sometimes specifically azithromycin or Zithromax can be used for patients with COPD, not necessarily because of bacterial burden, but because it's actually a very potent anti-inflammatory medication. So sometimes we'll use that for that indication. And then again, there are certain populations where they might be at risk for much more significant bacteria. So thinking of, again, the cystic fibrosis population tend to colonize bacteria that would be much more harmful to patients who didn't have cystic fibrosis, and they can require more potent or stronger antibiotics. Sometimes they take these inhaled, sometimes they take them orally, and sometimes they take them by IV. Obviously, we want to be judicious with antibiotics for all the reasons you all know. We don't want to breed resistance. We don't want your bugs to become resistant. And then, you know, we certainly don't want to ever have patients develop an allergic reaction. Obviously, the GI upset that some of you may know about antibiotics use. So it can disrupt the flora or the natural bacteria that live in your gut, and that can cause diarrhea, vomiting, nausea. So we usually instruct patients, again, to try and minimize how much antibiotic they need or are getting, or to try and take things that will help promote the natural antibiotics that are within your gut. So trying things like acidophilus or eating yogurt that has live cultures in it can be very helpful. And again, just the warning about trying not to overuse antibacterial medications. And then, so treatment for the flu, the biggest thing is prevention. So getting your flu vaccine, staying away from people who are sick, washing your hands frequently. All of those things are critical to keeping you safe. And then if you were to develop the flu, it's really mostly about supportive care. There is a medication to treat the flu called Tamiflu, but basically the studies have shown that it's most effective if you start it within 48 hours after symptom onset. We do sometimes give prophylaxis. So that means that if you live with someone who has developed the flu, we can give you Tamiflu in a different prescription than you would take if you actually had the flu. It's a little bit longer period of time. And the idea being that that could prevent you from developing the flu if you're high risk. I'll just go back real quick. Also, staying up to date on your other immunizations are critical for keeping your lungs healthy. So specifically, we think about the pneumococcal vaccines as well. So alternative remedies, there is just not as much evidence out there for kind of more naturopathic or herbal remedies, although certainly if you're working with a nutritionist or somebody who practices alternative medicine, you know, it's just important for us to know what you might be taking, again, just so we can watch those interactions with the medications that you're prescribed by your physician. So that is the gist of most medications that are used for lung disease. This changes and is growing pretty rapidly. And again, for some other diseases like interstitial lung disease, they're making gains in that regard pretty rapidly. So this is kind of an ever-changing science and an exciting time for us to be developing new therapies for different diseases. All right, thank you so much.